in diabetes management and is recognized for his expertise and clinical insights. Dr. Anjum will now present on therapeutic inertia in the management of diabetes mellitus. Please join me in welcoming Dr. Sohail Anjum.
Bismillahirrahmanirrahim. Thank you very much, LDF and PCDA, for organizing such a wonderful event today. I want to extend my gratitude to Professor Ahmad Shaukat, Dr. Ijaz Anwar, Dr. Ahmed Shahzad for organizing such a wonderful academic scientific session in Faisalabad and make it a pivotal point for learning in the field of medical and research. My today's talk it's a little bit different perspective. Most of us are well aware about the guidelines in the treatment of diabetes. But today we are going to discuss a very important topic which is often neglected, therapeutic inertia. Therapeutic inertia is actually inability to make adequate adjustment in the treatment of your patient when the right time is there. It is just delaying your treatment and making not a right decision at right time. So it has a different implementations, and it will increase the overall morbidity and mortality of your patient. While managing diabetes, what single goal is in your mind most of the time? It's different for different physicians. Many times you might think to bring the numbers right. It is in terms of HbA1c. Sometimes it is a lifestyle modifications. Sometimes it is diet. Sometimes it is trying different agents and combining together. So it is a different approach for every physician tailored to their patient needs. It is not about working harder. It is always working better and working smarter. That is going to produce much better results for your patients. It is said that a picture worth about 1,000 words, but it is not the picture itself, it is the way you see it. The data is there, all the guidelines are there. If you are not able to use those guidelines according to your needs, according to the tailored according to the needs of the patient, you would not be able to produce the results which are required. A total number of patients with diabetes continues to increase. About now you can see there, Pakistan is unfortunately is number 3 and becoming rapidly a diabetic capital of the world. The numbers which are about 700 millions, which are going to be achieved in somewhere around 2040 or 2045. Unfortunately, 5 years before, we are going to hit that number. Over 30% prevalence of diabetes in Pakistan, and about the same number in pre-diabetes phase. I think it is a bomb which is going to explode. Only while giving the treatments, while chasing the pharmacological management, won't be able to produce the results which we are looking after. Pakistan is a poor country. We do not have enough resources to provide or to cater the needs of all of our patients. So our approach should be more pragmatic and more holistic to get the results while using minimum resources. So there is a formula about clinical inertia. One way to calculate inertia is 1 minus C over H. where H is the number of visits, with a high A1C, where C is the number of visits in which a therapy was changed. So if a patient has visited you 4 times, for example, with a higher A1C, and only 2 times you make a treatment change, so your clinical inertia is about 50%. So each time, whenever you see your patients in your clinics, you need to make a bit change tailored to the needs of your patient. Otherwise, your clinical inertia is going to affect your patient. If you don't take the time to tackle the clinical inertia, then clinical inertia is going to deal with you and your patient won't be able to enjoy the old age benefits because your patient would die young most likely. One of the clinical inertia is, most of the time we see A1C levels in our clinics, we just see it and we move on. So this is one of the clinical inertia that we should be familiar with the guidelines. For example, ADA guidelines, ESD, they say HbA1c about 7%. If you see your patients, HbA1c is 9, 10 and 11, please do not skip it. Go into the details, try to find appropriate treatment which is required to bring that A1C level to an optimum level. As all of us are well familiar that merely a 1% reduction in HbA1c, your patient is going to enjoy a massive compounding benefits of reduction in microvascular complications or macrovascular complications. Overall, there is 21% reduction in all-cause mortality, about 14% reduction in heart rate, 12% reduction in stroke, and 37% reduction in microvascular complications, and about 43% reduction in major amputations. So merely if you just lower the number, A1C about 1%, you are going to give a massive benefit to your patient. So the first clinical inertia, I think, is to tackle the numbers. We need to bring the numbers into the right range. And the second one is, despite increasing number of new diabetic medications and techniques, overall our patients with a higher A1C level more than 9, they have jumped from 12 to 15%, and this slide and data is quite recent. It is from USA, where most of the treatment is insurance covered. Whereas in our country, the number unfortunately would be much higher. Usually there is about, this is very horrific, about a 6-year cap, a clinical inertia from the physician side, about we took 6 years to change from one agent to another agent or to add on a third agent. And the situation is not different in many developed countries where the clinical inertia is unfortunately is the driving force for increasing overall cardiac morbidity and mortality. Adding insulin or first injectable injections, you are well aware that a physician would take many years of thinking, processing, and then finally concluding that your patient is going to enjoy the benefits of injectable treatment, but the time has passed, the damage has been done, we cannot undo what has been already done. So it's a progressive disease. Once you see a patient in your clinic for the first time, it is already 5-10 years past. The legacy effect is going to affect. 37% patients already have some sort of micro or macrovascular complications before you diagnose your patient with type 2 diabetes. So do not forget to screen for different complications, because it is not the first time you are diagnosing your patient. Your patient is already late about 8 to 10 years. So we usually fail to calculate or to do a risk stratification. Hardly any physician is calculating all these factors, because if we calculate these factors, you can see in percentage ASCVD score, there is a Framingham score. If you calculate all these risk factors like high BMI, strong family history, inactive lifestyle, smoking, dyslipidemia, higher age, blood pressure. If you combine these factors, you are going to add more agents and to lower the overall cardiac and risk of the patient, but we are not doing it because of the lack of time, disease schedule, and maybe your patient is suffering due to that. Diabetes was nowhere among top 10 diseases 20-25 years before, but we are in number 5 or number 6 in terms of diabetes, and I think we will be hitting number 3 and number 4 in coming years if the same trend continues. So it is very important that whatever we can do, we should do it. Blindness is a major cause of, the major cause is diabetes globally. And if a person is blind, not only his life, his professional life, his driving skills, his all the career, all the approach is changed. So if we calculate the risk earlier, we reduce their risk, the blindness may be delayed, or its severity might be reduced. What about the diabetic kidney disease? About 44% new patients are due to diabetes, unfortunately. In Pakistan alone, more than 125,000 patients die due to CKD or DKD, you might say, on dialysis. Every year, we are seeing over 100,000 patients with kidney disease in our country alone. So the leading cause of end-stage renal disease, it is no wonder, it is diabetes itself. So the major amputations, apart from accidents, over 60% major amputations. So if you are not checking the pulses in your clinic, you are not giving importance to the foot examination, you are not doing Doppler examinations, you are neglecting calluses, you are neglecting ulcers, you are seeing your patient's pressure bearing areas are not equally distributed. Your patient is a future risk for some sort of amputations right in front of your eyes. If you are suffering from clinical inertia, just merely 1 minute of your precious clinical examination in your foot clinic or in your busy practice, I think your patient is going to save their name in future. So we should not ignore this very important step. Merely examination of 1 minute examination is going to save many limbs. It has shown in many researches. So the people with diabetes, they have already 2 to 4 times more risk of developing cardiovascular complications. So do not hesitate to calculate ASCVD score or Framingham score, calculate the 10-year risk, 20-year risk, try to modify that. If you need to add on Lyallpur, you need to add on statins, please do not hesitate. If the risk does allow that, you think there is a strong family history. As a subcontinent race, we already had a risk factor for developing cardiovascular morbidity and mortality. So if we are not doing, if your patient is complaining of shortness of breath and we are not doing enough in terms of checking their cardiovascular risk, your patient would end up with MI or hospitalization and their entire life would change afterwards. So the cardiovascular disease is a leading cause of death among people with diabetes, 2 to 4 times more. So what gets measured gets changed. So this is a slogan for time and range concept, because A1C does not tell the entire story. So this is another point of clinical inertia, that we think A1C is 6.5, we think it is 7, but we are neglecting. Your patient might have many episodes of hypoglycemia, many episodes of hyperglycemia, but overall HbA1c might not tell the entire story. So how we can get it? We can see the time and range concept. If we can check the blood sugar levels in real time, then we can see that how much blood sugar is in the morning, is in the evening, postprandial, and while calculating, we can see that the suggested range between 80 to 170 milligram. If your patient most of the time is enjoying that range, there are chances that they are going to enjoy the additional benefits of 10% reduction in micro and macrovascular complication. Mere 10% increase in time and range, unfortunately there is 44 to 64% increase in microvascular complications. So this number is outmatching your expectation. So it is a compounding adverse effect in terms of microvascular complications and macrovascular complications. This is a real data from CGM from one of my patients. You can see there you can have a holistic approach. You can see from morning to evening, their evening meals, your patient, whatever lesson you are going to give, hours and hours of lectures, of diet plan, nutrition, it is not going to work. Until you put a device, your patient is going to see what they are eating and what they are getting. They will change their approach. They are the one who will tell you, doctor, ask your patient, they should not eat this bread, they should not take this meal because it is causing a massive thing. So this is what we have taught in nutrition. If we combine it with CGMs, with the new glycemic control methods, I think there is then there is inertia in terms of clinical guidelines. We should not hesitate to use the GLPs, SGLT2 inhibitors. Metformin is no longer among the starting treatment regime for most of our patients. It is the SGLT2 inhibitors and GLP-1 analogs. The cardiovascular risk, please address the hypertension, dyslipidemia and all those factors. Do not hesitate to select a first injectable treatment, and then at the end there is a polypharmacy. Always try to reduce the number of pill burden if you can do it. Hypoglycemia, Dr. Musharraf already explained in detail. It is a limiting factor. If physician think hypoglycemia is going to cause a massive damage, then he is not going to control the blood sugar levels adequately. At the end, there is a massive clinical inertia in terms of the medical gadgets. There is a fear. Our physicians are not familiar with the gadgets, so they do not offer to the patients these new magical modern marvels for the treatment of diabetes. I have all these gadgets in my clinic. It is always free. If any physician wants to get in line of any kind of CGM, I have all kind of CGMs, many kind of the insulin pumps, and then the plantable, disposable insulin patches. I have all those things. If anyone is interested, please feel free to contact me for familiarizing with the modern gadgets. And that so the message for clinical inertia is always do something. When your patient comes to your clinic, try to evaluate the risk factors and evolve your strategies accordingly. Thank you very much for your patience. Thank you.
Thank you, Dr. Sohail Anjum, for that comprehensive and thought-provoking presentation. Heading towards our last presentation, I am pleased to introduce Dr. Ali Arif, Associate Professor of Medicine at Shaheed Zulfikar Bhutto Medical University. Dr. Arif is highly regarded for his expertise in metabolic disorders and diabetes management. Today, he will share his insights on the intricate interplay between obesity, metabolic syndrome, and gestational diabetes. Please join me in welcoming Dr. Ali Arif to the stage.
Thank you so very much. Bear with me for a moment while things are loaded on the laptop. You've already had a very, very interesting overview from some very, very good speakers as well. Dr. Sohail's been a colleague of mine. We've traveled to numerous destinations together, hopefully many more to come as well. So without further ado, we're going to start now. My topic of discussion is the interplay between obesity, metabolic syndrome, and gestational diabetes mellitus. I'll be talking about the recent advances in the pathophysiology and the management. Let's get this device working.
लैपटॉप में